similar to this, except that the parvovirus infection and the damage was all posterior. Now, of course,
Nihaal,
that patient did not have MOG and NMO positive. No.
Nihaal, I missed your point. In the second MR, you have a lot of destruction. Am I correct?
Yes, yes,
So this is in favor, I think, of an infection and
yes.
not an
Not in
autoimmune
favor of
disease.
MOG. Yeah, yeah.
And you have 2 virus positive and you have 3 antibodies positive. So this is a little bit confusing. And to have NMO positivity at 9 months is also very unusual, isn't it?
Yes.
So this is,
Yes,
I
yes,
think, in
yes.
favor of an viral encephalitis with destruction.
Okay. But clinically, actually, there was a period when he was well off and then he again developed the worsening. So clinically, he's behaving like more of a post-infectious NMDR encephalitis to us.
Correct. I think so.
And actually, he has no response. So we gave already 2 doses of rituximab. So with that also, the response is not like he will receive the full course, but with that also, even the response is not that much.
If you can do a parvovirus IgM, you should do it.
Okay, sir. Okay. So, sir, did you give anything like when he was parvovirus positive in the initial phase, sir?
Well, he came with this and we diagnosed the parvovirus, but by that time he already had the injury, so we did not.
Okay, okay, sir. Okay.
And they really came to us at the time when the NMDR was, and he did not improve very well, even though he was given rituximab. He improved, but there were lots of deficits.
Okay, sir. And sir, how old was he, sir?
I think about 1.5, 2. I'll show you the spare. I don't have it on this computer. I'll show it. I'll send it to you on the pictures.
Okay, sir. Okay, thank you. Thank you so much, sir.
Right. Thank you, Dr. Saini. Thanks for the case. All right. Coming down to Hyderabad, if Anna Sarapura there, over to you.
Yes, sir.
Yeah.
This is a 12-month-old male child who's a diagnosed case of B-cell ALL. This child was in the BFM protocol in the induction phase, followed by conduction and hypoleukocytosis. The child had received intrathecal methotrexate, hydrocortisone, cytarabine, vincristine, asparaginase, daunorubicin in January, and intrathecal methotrexate in February, followed by cyclophosphamide in March. Then the child had febrile neutropenia since April. So in view of no other site of infection that could be delineated, the child underwent MRI followed by lumbar puncture as a part of diagnostic workup to rule out meningitis. So the MRI scans.
Yeah. So the MRI, we have T2 and flares. You have generalized volume loss in the brain with periventricular and deep white matter changes, confluent abnormalities on both sides. I cannot appreciate any focal lesions on these sequences, but yeah, the main picture is the volume loss with periventricular and deep white matter changes on both sides. No subdural collections or no extraction collections on the flares. Posterior fossa is relatively normal in comparison to the supratentorial changes. On the diffusion various sequences, no areas of restricted diffusion. And yeah, this had just to outline the midline structures, again, some degree of volume loss in the brainstem and the corpus callosum, also some degree of vermin atrophy out there. And the follow-up was, yeah.
Yes, sir. So the ferritin was high, 3,470. Cultures were sterile. AFB was negative. Galactomannan was negative. Antifungals were ongoing, voriconazole. Brucella, Wheels, Felix, Vidal were negative. Lumbar puncture, which was done, showed 32 proteins, 33 sugars, and 12 cells, out of which lymphocytes were 92. CSF, TB PCR was negative. Cultures were negative. CSF comprehensive panel, which was sent, that showed CMV PCR. So the clinical suspicion in this case was like whether methotrexate toxicity or CMV leukoencephalopathy could present with this picture.
Okay, so the periventricular pattern, deep white matter pattern is typical for methotrexate toxicity in the acute stages. I think we see restricted diffusion, whereas in non-acute stages, I think the diffusion fades away into precipitated diffusion. CMV leukoencephalopathy in the non-congenital variants, I could find only one case with this pattern. So I don't have any experience with CME leukoencephalopathy in this age group. The white matter changes appear similar to both, but I think in probability, given the methotrexate injection, we're thinking more of methotrexate toxicity in the subacute or a chronic stage as the first possibility. Yeah, I'll open the case now for the panelists to add their input. Apurva, there's a question from Sridhar. What was the CMB log ratio?
CMB, CSF, right now we don't have that.
Okay.
So unbalanced methotrexate toxicity is the most likely explanation.
Yeah. Yeah, I think we're going methotrexate. If there are no additional comments or alternate views, I think the changes are more typical for methotrexate related injury. Any treatment related issue questions, Apurva, for this or?
If was positive, then so we started the child on cancer.
Okay.
Why is the ferritin high? Is it part of this methotrexate thing? Or just acute phase reactant?
So because the fever has been ongoing for a long time, so probably as a part of acute phase reaction, the ferritin is high.
Okay. So I don't see any alternate views. So we're going with methotrexate as possibility, but treating for CMB since it's come positive. And Sridhar has asked for log ratio, which can help in diagnosing the false positive cases. Maybe that we can review, Apurva.
Thank you, sir.
Okay. Next case, again, over to you.
So this is regarding a 5-year-old female child. She presented with fever for 5 days with cough cold. On day 2 of illness, she had a generalized tonic-clonic seizure, following which she became encephalopathic, and she did not become back to baseline since then. She had intermittent posturing, which required intubation. The GCS at the time was E1 VT-M2. CT was done on that the same day, on 19th. It was apparently normal. We don't have the films. So they came to us on 22nd. So on examination, her GCS was E1 V2 M2, and she had a right-sided pupillary dilatation and ptosis. We had got an MRI done.
All right. Okay. MRI, we have diffusion and ADC sequences. Confluent abnormalities demonstrated in the bilateral hemisphere, predominantly in the subcortical deep white matter. Some degree of transflow on the cortex out there. On the phase sequences, again, the edematous changes, again, subcortical cortical regions. No focal abnormalities. On the imaging pattern, thinking of acute leukoencephalopathy with reduced diffusion, we have questioned the terminology of this diagnosis, but the imaging pattern looks similar to what we have seen in these cases. The possible etiologies can be infectious and toxic related etiologies, and if there's family history, can be genetic abnormalities. So after the MRI, the child, yeah, you can take it from here, Anas, the condition and the reason for the CT.
So we started the child on IV and other supplements, which we usually antioxidants, which we usually some for ALARD. So on 24th, we had gotten a CT to see any interval changes. And post the CT, we had continued on the anti-edema measures. So from 24 to 29, there was a static phase. There was some improvement in the reactivity, like eye opening was there, but no fixing or tracking. Some meaningful flexor response started to develop. So I was triggering the ventilator. So we thought maybe we are on the improvement. When we're debating to put a tracheostomy or not, but as the child was starting to trigger, we thought, okay, we'll maybe try to put the child on CPAP trial. But just before that, on 28th night, child deteriorated, had
Wait,
hypertension.
wait. Let's see 24 first.
Yeah, this is 21st.
Okay.
First.
So 24th, a follow-up CT was done, and with the limitation of the comparison, you can see there's progression in the edematous changes, and compared to the MRI sequences out there, almost like a white cerebellum sign demonstrated here. Yeah, so complete effacement of the circle pattern, and there is progression in the edematous changes. Yeah, after that, yeah. Anas, yeah, okay.
Yeah, so on 29th night, she had hypertension, BP was systolic more than 220, and she had again posturing, and from then she stopped with triggering the brainstem dysfunction. We had done EEG, which was not reactive, and actually on 24th itself, we were debating if any surgical intervention would help, but as she was holding on, as it was a cytotoxic edema, we waited. But on 29, she deteriorated, and then I think it was from then she went into complete brainstem dysfunction, and we counseled them, and they had decided to discontinue care and taken to their hometown.
Yeah, so again, 5 days follow-up, again, progressive changes. You can see that the herniation, especially the descending tantalizing herniation, has progressed in comparison to the 24th scan. So significant, interval progression in comparison to the MRI, CT, the first CT and the second CT. The question here, I think, Anas.
Yeah, so we're not
Yeah.
sure exactly what what made the child person after a relatively stable phase of so not sure. She did not have any seizure, at least from the EEG, no electrical seizures. And that was the main question we had, and the changes which we saw in the repeat CT, I thought we were wondering if there was some other alternate explanation for this, especially the cerebellar hypodensities. We had done LP earlier as part of workup, which was normal, and even the markers for HLH were negative. But thing is, we had done clinically it was not a match, but as part of this workup we had done. So we're not sure if could have done something differently in this case. Or intervening on 24th would have made any difference.
Did the child have an EEG?
Yes, sir. So we had done 3 times. Initial 2 were low voltage delta wave activity, 10 to 20 microvolts.
No non-convulsive status.
No, sir. Yeah, MOG we had sent actually just to understand more than suspecting. We did get the report today. It is mildly positive, but we had a discussion with the team. They said in the context of this thing, maybe it may be a false positive because IL-6 was done. It was 46, 4.6. The MOG was positive, but maybe it's a false positive because of the extensive cytotoxic lesions. Not sure if we did give steroids as well, and IVIG. We did consider, but not very sure if it's a true positive or not.
Sorry, I just joined. I missed the clinical bit, and the MRI looks very MOG-like. How would the child present clinically?
So clinically, it's the child.
Okay.
Yeah, sorry.
Oh yeah, so that sounds very. So actually, all these cortical encephalitis, we recently put together a cohort that is now in review. 75% will have. They basically have what we say with encephalitis: headache, fever, and seizures, with 78% having lymphocytosis in the CNS. So, and the MRI, I don't know what he's thinking, but it's very much like the cases that we put together.
So you're saying this can be a MOG-driven encephalitis resulting.
To me, it's not even MOG. This was very MOG-like, and I think more and more. I don't know.
Yeah.
I'll be very interesting to see what if you guys can look at like all your meningoencephalitis. At least in London, I feel like we never see viral meningoencephalitis, and actually every time now I see viral meningoencephalitis, cortical changes and cells, they're more cortical. And the presentation is textbook meningoencephalitis, headache, fever, and with these MRI tests, and they're all MOG. And the difference is that if you treat them and give them steroids, the lesion can resolve completely. If you treat late, some of them get this scarring, kind of, the cortical scarring, let's say. But if you treat them quickly, they may completely recover.
So we did actually we're not sure if it is really MOG, but we did send. We have given steroids and IVIG. Tocilizumab, the child had continuous high-grade fevers, so we decided against it. Actually, the steroid itself, we had a debate with the ICU team, should we be going? But we did, and the benefit of doubt, because we did go with steroids.
So he got steroids or he didn't get steroids?
And we had a Klebsiella positive sepsis as well. So that was the reason we did not go with tocilizumab. But yeah, maybe we should have. Maybe I don't know. It would be better I mean, is there any like biomarker that we can use to decide on tocilizumab? Like usually we're not doing CSF IL-6.
So CSF IL-6 is a good biomarker. I think the question is when you decide, to escalate. And we had that case, I think maybe a month ago, also with MOG. So we were talking about the craniotomy. So it seems to be that patient that seemed to, at least from kind of the international, it's the patient that seems to get everything, and you don't really know what is the one that makes the difference. And I remember Professor Danny by a month ago said, "Oh, if you consider, craniotomy, you should do it." But those patients are really the kind of get malignant, encephalitis with very high pressure. These are the ones probably to give us tocilizumab. But is this patient clinically improving, or how is the patient doing now?
No, patient is dead.
Oh, okay.
I had a question. If you have a weak positive MOG, that's titers are usually 1 in 10 or lower, right? Am I right?
So the one we got was 1 in 10 dilution. They have reported as mildly positive at
No, in the sense, if it is weakly positive, I mean, it could be a false positive and you need to repeat it again. Now, of course, in this case, you can't, but.
Oh, sorry, I didn't realize this patient. And this patient didn't get a craniotomy.
No, that was the question here. If should they have intervened on the follow-up scan for a craniotomy at this stage at least?
Yeah, and I think the answer is actually yes to craniotomy, not necessarily for tocilizumab, because tocilizumab takes 7 to 10 days to start working. So if you have a child like this, tocilizumab wouldn't have saved them. Craniotomy maybe would have, but tocilizumab takes a long time, long in this sense, time to work. You can't expect the response to be quick. You want something to drop the pressures in immediately.
The plasma
so
exchange.
I think the question about. But I also think the plasma exchange, again, it's all about timing of effect. So I feel like plasma exchange is unlikely to have been life-saving if the pressure was that high. Maybe if you would have started plasma exchange, earlier on at the same time of steroids. I mean, I don't know, it's hard to tell, but I think these patients, and if you look at even if he wasn't MOG positive, in every ADEM or ADEM-like cohort, there's always this 5% mortality, and this normally from this pressure effect, and it's really only a neurosurgical intervention now, because it happens very quickly.
So this is within 2 days. I mean, there's significant progression in 2 days. So yeah.
Exactly, very, very quickly. And even if probably a day into it, it was also already very disabled. So those decisions need to be made a lot of the time in the middle of the night. It's not let's give tocilizumab and wait 7 days for the patient to be
Thank you. So if I have to summarize, so it's better to do surgical intervention early to give us some time, so that meanwhile the tocilizumab or plasma exchange works. Am I correct?
Yeah, if it is so diffuse, I mean, not for the
Yes.
multifocal abnormalities, but yeah, this diffuse process, I think,
Sure.
especially of the second
With-
CT would have been
Because
helpful.
we have another child presented to us like 2 days later. It was an ALERD, but a central sparing one. And that
Yeah.
child we were able to discharge him home actually without him in much.
Yeah.
We had just given IVIG, that's all, and other this thing. I think maybe it's the
Diffuse.
similar MRI, only central sparing. That's all. That's the only
Yeah.
difference.
Yeah.
Maybe,
There was
I think.
one mock we had last month, I think, under Dr. Nikit also had
Yes,
progressed.
yes, that another child it was.
So I thought maybe with that experience you could have done something. Okay. All right. Yeah. So that's the thing. Anatomy would have been helpful for it. Maybe it would have been helpful at this stage.
Thank you.
Okay. Over to you, Anas or Apurva, who is presenting.
So this child is a 13-month-old male child, came with complaints of developmental delay. He had gross motor delay such that he had partial neck holding, only rolling over, and not reaching for objects, only cooing. Cognition maximum, he would recognize his mother. Then he had seizures from 5 months of age, epileptic spasms that started in clusters. With no significant any perinatal history and non-consanguineous marriage. On examination, the head circumference was 42 microcephaly, length was 74, weight was 7 kgs, and he had central hypotonia, minimal weight bearing, head lag on pull to sit, and brisk reflexes. The MRI, which they came with us, we have.
Okay. So the MRI, this was before MR or after MR? Sorry. Okay.
Yes. So,
sorry, go ahead.
Sure, sir. Lactate we had done, that was 3.3, and TMS with biotinidase we sent, which was normal. And that time, based on MRI, we'll rediscuss the.
Okay. Okay, so I have only limited images of the MRI, of limited film. So this is a T2 axil here. You can appreciate some degree of volume loss more on the frontal lobes and the temporal lobes out there. In the globus pallidus, you have these T2 hyperintensity, slightly asymmetrical, more on the left side. The bilateral cerebral peduncles have a more symmetrical pattern of T2 hyperintensities. Other than that, in terms of signal changes, like, what was the age? Sorry, I didn't get it.
13 months.
13 months, okay. Yeah, some degree of delayed myelination out there. The anterior limb capsule should have been myelinated by this stage. The paracentral white matter also demonstrates delayed myelination. So some degree of delayed myelination, some volume loss, changes in the globus pallidus, and in the bilateral cerebral peduncles, mild lateral ventromegaly and third ventromegaly on these images. All right, we can ignore the flare, look at the axial, the sagittal sections. Again, the corpus callosum is thin, atrophic, but other than those changes which it's on T2, we don't have a diffusion or a SWA sequences to add any further information. So we are dealing with cerebral atrophy, changes in the globus pallidus, the midbrain, corpus callosum thinning, and delayed myelination. So based on that, I think we evaluated for possible mitochondrial disorder and the. All right. I don't have any.
Can you comment on treatment? Steroids, vigabatrin, anything else?
The child received steroids for epileptic spasms, but not vigabatrin.
This may explain the so-called atrophy.
Atrophy, yeah.
Depending on the duration.
No, so after the child came to us, then we started
Okay.
steroids. Before that, the child had not received steroids.
Okay.
Okay, so neurodegeneration at the time of presentation.
Why did you consider a neurotransmitter disorder? On what clinical basis?
There was some striatal toe, and otherwise no other such family.
Yeah, I cannot think of any neurotransmitter which fits this maybe creatine deficiency, but I'm not sure if they have cerebral peduncle abnormalities, methylmalonic cobalamin deficiency. Suppose there's a question is, were the spasms since 5 months of age? Is that true?
They started from 5 months of age, so.
The Vijay NCL, but with brainstem and deep brain nuclear changes, I'm not seen in NCL.
The age and the presentation, in my opinion, does not fit to NCL at all. NCL3 is the juvenile form. NCL5 is one of the late onset, the late infantile forms. They don't start in the first year with infantile spasms.
Would a cobalamin pathway deficiency fit, Apurva or Aigan, or given the global status changes, the atrophy and the myelination abnormalities?
So we have not evaluated for that. Could be a possibility.
Would that give rise to cerebral peduncles? Those seem to be more mitochondrial than anything else. Brainstem changes.
Yeah.
And lactate also was 3.8. So that's why
You
we were
didn't do a
considering-
CSF lactate?
No, sir. Only serum lactate we had done.
Yeah, Dr. Sayani, the ones, the mitochondria involving the globocellular PDH is the most common one. Yeah, I agree. But they're usually more swollen in appearance, possibly given the chronic stage of this disease. Was there any response to rise, Apurva?
This child has come recently only, 4-5
Okay.
days back, so it will take some
Okay.
time.
I may have missed the point. Is genetic
Yeah.
investigation in the pipeline?
Yes, sir. It has been sent. Report is awaited.
No clinical images.
No,
Dr.
not
Vivek,
available,
yeah.
sir.
Yeah. All right, Dr. Vijay is asking for a possibility of glutaric aciduria.
Glutaric aciduria almost never starts with seizures.
Okay, so I think we're thinking in the same lines. Genetic disorder possible with mitochondrial or neurotransmitter. I'm not sure of the neurotransmitter, but mitochondria can be a possibility. And I was also thinking of cobalamin pathway disorders as one of the possibilities.
Okay, sir.
Would a repeat MRI be useful in a few
I think
weeks?
an MRI with all the sequences will be useful.
I mean, if you consider a allele-like
Yeah,
mitochondrial
yeah.
situation, you may have a dramatic change in a short time.
Yeah. Any history of hypoxia, Apura? Dr. Vivek asked. I don't think so, Dr. Vivek. I don't think there's a history of hypoxia.
No.
Yeah. Yeah. I remember this point. We have discussed this in a couple of cases. But yeah. I think a follow-up, if the genetics is negative, I think a follow-up MRI might be helpful. So we'll come back to this case once we get the results.
Yes.
Yeah, thanks. Okay. Anas or Apurva, over to you.
Yes. So this is a 9-year-old male child. He was premorbidly normal, going to school regularly. So he had headache for 5 days. So with vomiting, multiple episodes, 3 to 4. He didn't have any fever as such. Headache was moderate in nature, vomiting multiple times per day. So when he came to the OPD, there was clinical examination. He was a bit lethargic, but responding appropriately. There's angle of deviation of mouth to the left. His heart rate was 58, BP 105/68. Some neck stiffness and kernicks was positive. So, based on the headache and vomiting, we suspect some intracranial space occupying lesion. MRI was done, which is as follows.
Okay, neck rigidity, kernicks, no meningitis.
No fever as such, but
Okay. Okay. All right. So T2 axials here, you can appreciate there is an extensive abnormality in the left hemisphere. Also, some changes on the right frontal lobe, some white matter abnormalities out there, but predominant changes are in the left hemisphere. Confluent abnormalities infiltrating into the deep brain nuclear structures. The basic ganglia you can see is thickening, demonstrating slightly heterogeneous T2 signal changes. There is some mass effect on the thalamus by the internal capsule out there. You can see that this concave margin out here. Coming more, you can also involve the cortex on the frontal lobe, the perisylvian region, the temporal lobes. So cortical changes demonstrated in the left hemisphere, also crossing the midline up to the basic frontal lobes on both sides. And again, the extensive abnormality is in the left hemisphere, but some changes were also seen in the right frontal lobe. On the diffusion sequences, could not appreciate any areas of true restricted diffusion. None of these changes, or there was no reversal on the no hypointensity in our ADC sequences. The SWS sequences did not demonstrate any areas of blooming, which could possibly represent hemorrhage or calcification. Post contrast, there was no significant enhancement in these areas, no optic neuritis, no leptomeningeal enhancement, no significant parenchymal enhancement. Spectroscopy was done, demonstrated a elevated choline peak with a reduced NA. There's a mildly elevated lactate peak too. The choline NA ratios also were abnormal, and so based on these findings, we're thinking of possibilities of diffuse glioma. These are again the examples where the imaging picture is somewhat similar. At least in the first case, you have this diffuse infiltrative abnormality involving the white and gray matter structures. That was one of the considerations. The other point was given to was it an inflammatory condition, but there was no contrast enhancement, no diffusion changes. These are the extensive abnormalities which can present with these imaging patterns. An example of HASP, an example of PML, but this child does not have any immunodeficiency status. So yeah, we're thinking of neoplasm diffuse glioma as one of the possibilities. I think the child has undergone biopsy or in the process of undergoing a biopsy. So if there are any other suggestions or inputs, that would be helpful.
Specimen wise, the finding was it was a pale tissue with necrosis.
Okay.
So maybe that is more.
Just one question about diffuse glioma. Do you get hypointensive T2 commonly?
On the no, they are two. I mean, the high grade Hamans may have hypointensity, but these are actually all diffuse gliomas, Dr. Rani, and you can see that they're all T2 hyperintense.
Yeah, but I think this kid had a hypointense as well, right? Heterogeneous. I mean,
Yeah,
that's
the basal
very,
ganglia out here. Yeah.
yeah. Okay.
So sorry, Anas. Yeah, go ahead with I mean, what is the inference of the?
Yeah, so at least gross specimen, it looks like a tumor. Maybe glioma is what was the impression, but we have sent the biopsy and it's awaited. Meanwhile, we had two questions actually from the radiology point of view. The opposite area being the due to hyperintensity in the opposite area, right side. Is it like commonly seen, or is it maybe any point? Does it point towards anything specific? And second, more like clinically, I mean, the child did have some neck stiffness and kernicks, which disappeared later on follow-up. I mean, with just the raise ICP management. So is it just a reflection of raise ICP or something else?
Okay, the opposite side, I think can be adimatous changes alone. Anas,
Yes, okay. Answering this question, yes, we have stent mock, though we're not, I mean, it's a very remote possibility. We did send it just to understand, because the biopsy, so we did spend more. Not sure if because if it would be positive, but we did have
Child
sent it.
also had fever on the day of presentation to the OPD. He had fever and he had a very strong meningeal signs.
At least imaging wise, I don't have the inflammation part of it to cause it, but as someone has pointed out, increased cranial pressure can cause it. Is that right, Dr. Abhishek? Or
But that usually happens with tonsillar herniation, isn't it?
Mhm.
Was there any tonsillar herniation? No.
No, there was no tonsillar herniation.
I missed your point, likely. Are you considering biopsy?
We
I
did
can
done
biopsy.
biopsy.
Biopsy was done. The tissue has come out to be. Sorry, Anas, go ahead. Yeah.
Yeah, so it just the gross specimen wise, it looks like a tumor. It's pale tissue with some necrosis, areas of necrosis.
Yeah, I think the biopsy was done in the temporal region, if I'm not mistaken.
Yes, sir. Yes. Middle and inferior temporal gyrus has been taken up for biopsy.
So this is on the frozen, you've got glioma, right?
We have not gotten the report yet. So we have done it yesterday itself. So we have sent for staining. Meanwhile, we have sent MOG as well, just to understand.
So something like a tumefactive demyelination, but in that
Yeah,
also,
yeah.
So there's no enhancement at all, and
exactly, and there is no
I mean yeah.
hypointense white matter is also very odd in that.
Yeah. And the mass effect I thought was possibly not commonly seen in the monks, at least the cortical gray matter abnormalities.
Yeah.
I think Jayant has mentioned that hemispheric gliomas need immunohistochemistry. So Jayant, these are all examples of H3G34, the ABC are all high-grade gliomas. So I think we will be doing the immunohistochemistry. Okay. Yeah, we'll get back to you with the complete biopsy report and the immunohistochemistry report on the next session.
Thank you. Any other differences can we think?
Yeah.
Radiologically, tumor-wise, so it's like a glioma likely, diffuse glioma. Any alternate?
I think MOG was raised, glioma is raised. Yeah, other than that, I don't see any.
Thank you.
It's not fungus, right? No.
Child is clinically well, like is a very well thriving child. So we did not consider it actually. And fever also, it was fine next day itself.
Oh, okay.
So again, no enhancement at all, no diffusion at all. Not at all, but yeah, not very significant, at least in the infected. Dr. Vivek says GFAP. Dr. Vivek, I thought of GFAP, but again, the enhancement pattern, at least there should have been some perivenular or what we have seen, the confluent pattern, which you have seen in some of your cases. Yeah. All right. We'll get back to you with the complete follow-up in the next session. Okay, over to you, Razi. You're there.
Yes, sir. Like 3-year-old male child born to third-degree consanguineous parents, previously healthy child, had a history of high-grade fever and respiratory distress associated with generalized purpuric rash all over the body. Like 4 months back, for about a week, high-grade fever and rash was lasted about a week. Then after the illness, he had like excessive sleepiness and motor regression of milestones. Child was restricted to bed since past 4 months, and he had like weight loss of 3 kgs in past 4 months. He was unable to sit on his own, and there was loss of neck control as well, and unable to turn in bed. 1 month 1 month before presenting to the OPD, child had some improvement in motor activities. He was able to sit from supine position by turning to one side, walking few steps with support, able to grasp and hold the objects. On examination, the child weight was 9.5 kgs, and he had like severe acute malnutrition features. Malnourished wasting was there, and head circumference of 46.5. Microcephaly was there. No cranial nerve deficit. Proximal muscle weakness was there, and lower limb spasticity with BPR's breast. So we thought of like infective bar inflammatory, very genetic neurodegeneration kind of thing, like vanishing white matter brain disease with neurodegeneration was the initial thought. And we have advised for MRI brain and cervical spine.
Yeah. So I have the MRI brain, again, T2 axis and flares. Again, you have diffuse volume loss in the brain. Some patchy areas of periventricular deep white matter intensity is especially better observed on the flare sequences. Yeah, but other than these focal lesions, I cannot appreciate any other abnormalities. The deep brain nuclear structures are relatively preserved in terms of the signal changes. But yeah, generalized volume loss with these patchy hyperintense white matter changes. Nothing pops up on the diffusion sequences or on the SWI sequences. The cord did not demonstrate any abnormality. Yeah. So at that point, we thought, I mean, as Rajdi has mentioned, we thought it autoimmune or inflammatory or neurodegeneration, but not getting into the at least vanishing white matter. Also thought of SSP or measles related changes, but yeah, these were the main considerations at this point.
Child was admitted for LP, and the LP was like protein for 29 and glucose of 55 with 5 steps. Not much of inflammatory infective pathology thing. And in view of anti-measles antibodies were also sent, which were negative, with hemoglobin of 9.8 and WBC of 8,100 and platelets of 1.7 lakh. CAVs were normal, no hematuria as such. LFTs were like mild transaminitis was there with hypoalbuminemia, with ESR being elevated around 65 and plasma lactate of 1. And first, like in view of autoimmune suspected neurodegeneration, ANA was sent, which was moderately positive. So, like child was brought to the ER again 10 days later with high-grade fever and multiple episodes of vomiting and multiple episodes of seizures overnight. For about 12 hours, like he was having GTCS, status epilepticus, with impaired awareness. EEG was done, and during that time, like seizures have been subsided. It was well controlled, but EEG was showed like left hemispheric electrographic seizures, non-convulsive status epilepticus was there. So child was started on midazolam infusion, which was tapered over next 24 hours based on the EEG. And there was hypokalemia and hypocalcemia for which IV correction was also given. In view of suspected autoimmune by genetic neurodegeneration, TMS, GCMS, and C3, C4, and whole ANA panel was sent because ANA was moderately positive initially. So whole ANA panel was sent and rheumatology consultation was taken at this point of time. In ANA panel, we got this ribosomal protein strongly positive. 3+ was positive. So after rheumatology opinion, we have started child on IV methyl pulse dose, followed by oral maintenance and injection cyclophosphamide was started. There was a very good improvement in motor abilities. He was able to walk independently. He was back to baseline. We have sent this whole exome. We got the report yesterday only. It was showing C1QC positive, likely pathogenic, early complement deficiency. This was a case of like isolated CNS lupus with the CNS manifestations predominantly. Very few case reports have been published with isolated CNS lupus in children. But this anti-ribosomal protein, which is positive, is strongly associated with CNS lupus. And C1q deficiency is strongly associated with SLA, like almost 95% of the times.
Yeah, so I have the review out here, and you can see that the C1Qs are most commonly associated with lupus. As Razi has pointed out, we have around 88 to 60, from 65 to 88%. So the most common abnormalities are in the C1q band, but these are the other genes which can also present and associate with lupus-like syndrome. CNS imaging can be variable, can have focal lesions, demyelinating lesions, vasculitis, ischemic changes, these patchy abnormalities which were seen in our case, and also some inflammatory changes can be seen in lupus. So we wanted to highlight the case of predominantly isolated CNS imaging with the C1q association. And if anyone has any similar experience or any further inputs, welcome to point it out. I think that's it. Yeah.
Oh, sorry. I've got Nihaal's login.
Yeah, that's fine. That's
It's
fine.
very confusing. No, a very interesting case. I'm just wondering, just for the discussion. So, what do we think is the two questions? What do we think is the CNS biology of this, in the context of the genetic mutation with the functional, and also, has any of these paper reported what to do next in respect to treatment?
Presently, child is on cyclophosphamide pulse dose with good improvement in motor ability, and IV methylprednisolone initial pulse dose was given, followed by maintenance, oral maintenance, and gradually tapering dose. And we are planning to continue low dose maintenance of oral steroids for about an year. And 6 cycles of cyclophosphamides are planned. 3 cyclophosphamides are planned for this side. And as there is improvement, because this ribosomal P proteins are CNS specific, it has like auto antibodies which are CNS specific, which causes CNS lupus.
But what? So it's an antibody. Antibody in lupus are not pathogenic. They kind of cause a vasculitis, I guess. That's why I'm wondering. And also, if you look at the paradigm of like, the DADA2, there's another form of like congenital lupus. Then actually these patients use an anti-TNF. So I don't know if all these kind of congenital or neurogenetic lupus mimics needs to be, because you can't keep a child on cyclophosphamide for life. Is there any, even from like anything kind of, is this more of a complement problem? Is this what's
complement mediated CNS, like early complement deficiency can lead to autoimmunity, man. Initial early complement, late complement membrane attack complex deficiency led to infections related complications. Early complement
so we need to even be more worried these patients with, because they nearly have an immunodeficiency, or is it the same, or is it just like gain of function and a lot? Is this the different genotype, phenotype?
Like usually we see deletions in this. In this case, we have the duplication thing. Rare case of even QC deficiency.
So we had one more case, a similar case, which had multiple immunodeficiency related issues, had fungal abscess and CNS fungal infection. And when we evaluated that case, that child came out positive to be C1q esterase deficiency. But because it is associated with SLE, so we sent the NA panel in which this ribosomal antibody was positive. Though he did not have CNS lupus findings, but retrospectively there was an association. And we have started child on monthly FFPs for C1q deficiency.
And there has been like 7 studies which show that like, ribosomal autoantibodies, P proteins have strong association with CNS lupus, and fluctuation in the antibody titer can have the episodes of psychosis, like with fluctuation antibodies. And there is a good correlation with general disease activity with the antibody correlation, and direct role, like these antibodies cause a direct role in disease expression process independently. It inhibits the protein synthesis basically. And this C1q deficiency led to autoimmunity kind of thing.
Yeah. Thanks, Razi. Thanks, Apura. All right. So whenever we see isolated CNS lupus, think of the complement deficiency associations and send for a whole exome, I guess, or retrospectively, as Apura mentioned. Okay. Yeah. Apurva or one of you was taking, yeah.
4-year, 9-month-old male child. This child was previously developmentally normal. The child came with complaints of inability to walk. Like slowly, there was regression of his motor milestones as well as cognitive milestones. He had balance issues, increased falls while walking from last 2 weeks prior to coming. And then child also had slow head drops with slow eye blinking episodes. Gradually, the child stopped recognizing parents, speaking single words, very slow in responding to commands, and excessive sleepiness, but maintained sleep-wake cycle. But otherwise, the child did not have any major behavioral issues. The child was admitted in other hospital where the child was evaluated, and that time, in view of a process, probably considering cognitive and motor regression, possibilities of autoimmune encephalitis, and with some myoclonic jerks, SSP was considered, and CSF analysis was done.
No. Was it before the scan or after the scan?
After the scan, first MRI scan.
Okay. So let's have a look at the MR.
Okay.
So yeah, this is the first MRI scan. You have T2 sequence out here, and you can appreciate there is some degree of subcortical deep white matter changes in the frontal lobe, especially the left frontal lobe out there. The deep brain nuclear structures appear to be normal. Coming down more inferiorly, you can appreciate some degree of hyperintensities again in the posterior temporal occipital lobe on the right side. Better appreciate on the image on the right panel, the lower panel. Some degree of vermin in the folial pattern are slightly prominent on the vermis. But yeah, the main changes were possibly bilateral frontal, but more on the left side, and also in the right cortical region of the right temporal lobe. The phase sequences, you can better appreciate the abnormalities. Again, the frontal lobe abnormality, you have more noticeable changes in the bilateral temporal lobes, the occipital lobes, in the subcortical deep white matter and the periventricular regions. So the possibilities, I think, as Apurva has pointed out, these were what we thought of as possibilities: early stage of SSP, inflammation, autoimmune viral encephalitis, and yeah, after that, Apurva, the labs.
Yes, sir. So CSF glucose and protein was normal. Lactate was 1.1. Cells were 12, which were all lymphocytes. EEG, those myoclonias which were recorded showed generalized proximal shoulder subtle myoclonic events, followed by a period of loss of awareness. The ictal episodes were captured, and there was a burst suppression correlate in EEG.
Okay.
And autoimmune panel, CSF panel, which was sent for autoimmune antibodies, that was negative. And systemic auto antibodies, ANA was sent, which was also negative. And thyroid profile was normal. After which, and the child is vaccinated for age. The child received IAP vaccination.
Okay. So after that, I think the child had another scan 3 days later, 4 days later. You can appreciate on the phase sequences, there is some degree of, it is better appreciated, the changes are better appreciated now. Maybe some degree of progression. You have more bilateral involvement in the frontal lobes, the parietal lobes out there. Also, the temporal occipital regions have more noticeable changes on the phase sequences. Even if you see the temporal lobe out here on the right side, the gray white matter is not clearly appreciated in comparison to the left side. So within 4 days, I think there is some degree of progression. T2 sequences, again, can better appreciate the findings, again, similar to what we have seen in the phase sequences. Bilateral frontal, temporal, parietal changes. Spinal cord was done. Spinal cord did not demonstrate any abnormalities in terms of focal or long segment changes. Contrast was done. There was no contrast enhancement. Yeah, I think.
Yes, the measles antibody, it is positive, 3-fold elevation in the titer of antibody.
Okay. Dr. Abhishek, anything to add, or does it fit? I mean, I think we have Dr. Madhuri also, if they want to add anything to the case.
Yeah.
In terms of
clinically, it fits with SSP. The only thing is the rate of progression is too rapid. He just came with history of just 10 days to 14 days of the parents said walking difficulty, but it was more of a cognitive slowing, which was very evident.
Problem is sometimes it may have been going on for a longer time. It's just that the initial cognitive changes are missed. So was there any retrospective check of the scholastic problems and all? Of course, fulminant types can occur.
Yeah, so this was more of a fulminant presentation. The child was apparently okay until the beginning of March and then started having disinterest in his studies, did not participate well in the exams. And his speech became more and more laconic. He needed to be asked repeatedly questions. And thereafter, last 2 weeks, he started having falls, which correlated with the myoclonic jerks.
The
And
whole story
yeah,
is about 2 months, right?
I would say beginning of, yes, yes.
That would
So
be
somewhere around in the
consistent.
first week of March, yeah.
May I ask, is there a history of measles infection in the first year?
There's no history of measles in the first year. Child has been vaccinated, so has received the 9-month and 15 months MMR.
Problem is we see this very often. I've noticed this after COVID, we see even more. You have vaccination and for some reason there's some immunodeficiency. I don't know what transient and the whole thing comes. Did you do COVID antibodies?
No, we haven't got it done.
Of course, it'll be
So-
positive probably. Yeah.
So it's interesting that probably we still don't know about SSP, basically what this disease is, whether it's the real measles or something else. We actually are doing interferon scores in CSF in blood with Dr. Amit Rawat in PGI Chandigarh. And the first few cases, they are raised, like you have in Aicardi Gouttiere, the interferon score. So the scores are high. So actually, the most important thing is we should stop giving interferons first, because actually these patients have more interferons. And once we have 10 patients, we are thinking whether we should start giving them JAK inhibitors to see if that works. Just a
Which
proof of
one?
concept study, JAK inhibitors.
Jack.
So
Well, actually,
once-
the problem is that now there's the whole theory is on fusion protein. So the fusion protein, apparently the virus itself, the fusion protein is, so nowadays people are trying to think of a fusion inhibitors, like what you have that enfuritide in HIV, that kind of fusion inhibitors. So it prevents fusion of the measles virus onto the cell wall itself. But I don't think we have a medication as yet for that.
So, can you tell this again? So stop the interferons, is it?
Yeah, because the
I'm not-
interferon scores are high in the patients. So the first 4 patients we have sent, so they do interferon scores like you do in Aicardi Gouttiere, the interferons scores. So they are high. So well, this is
There is-
because most patients are immunized, most patients haven't had measles. So history of measles. So is there really a measles virus in the brain, or this is some sort of again tendency of some patients who have this inflammatory process which following a blood measles gets precipitated. So that's
No, but I think this has been fairly worked out, Vivek. I mean, there's a mutated virus, which is basically, usually a measles virus doesn't attack the CNS. But in this situation, because of the M protein, they get into the CSF. And then from there, the fusion protein, which is also a problem, helps it to transfer it from cell to cell. And therefore, you don't get the measles virus in the CSF. You get the interferon may be a secondary increase, right? Because of inflammation.
yeah.
Or
So,
whatever.
but at least we should not give the interferon.
But
Well, we did a study on this many years ago. And I agree, there were some patients who actually worsened with the interferon, but many patients did better also. So we don't know.
there's a study that showed that with the interferons and the isoprenosine, the remission could be attained in 36 to 38% of
Yeah,
the
that's the
cases.
same one I'm talking about, the multicenter study I was part of in
Right.
1996.
Yeah, no remission without the interferons. This is what that study mentioned. So
Yeah, but after
that's,
that, it's not really been very
replicated
successful.
again. Okay.
yeah, because isoprenosine patients waste tons and tons of money and it does nothing.
Interesting. So what's the new thing then? I mean, can anything be done or just leave them?
at the moment.
Enfumitide, is it proven?
No, enfumitide is basically a specific for HIV virus.
True, true.
There was a study in Japan where they actually they made a fusion inhibitor for the measles virus, and in the SSP mouse model, they actually showed that the mice improved or whatever, everything was improved and the virus was cleared. The problem is that particular specific has to be a specific for that particular virus, and I don't think right now we have access to that. It's only in animal studies.
Mm-hmm.
I'll send you the article. I'll keep
Yeah,
the
sure.
article.
Thank you.
All right. Thank you. Thank you.
For me, living in a country
again.
where I have hardly ever seen SSPE, this was a very interesting but most confusing discussion. Since you say these patients usually have no history of measles. If you do, I experienced a case, I think adopted from India, where there was evidence that the child had measles at the age of a few weeks and was later vaccinated. And of course, this vaccination was accused to be responsible. Anyway, I don't understand.
So actually, they say that whenever there's a subclinical measles acquired at a very young age, that can be one of the causes of such fulminant presentation, especially in these young kids, because this is a very atypical age of onset for SSP.
You didn't check for HIV, did you? Because there's a rapid in HIV. Sometimes we get a very accelerated kind of measles encephalitis. I mean, measles SSP.
I'll have to check about that. I don't remember getting it done.
All right. Okay. Yeah. Thanks everyone for the discussion. We have a similar SSP case from Dr. Savasni. Maybe I'll put that up on the next meeting. For now, we'll move on to the last two sets of cases from Dr. Vivek. So Dr. Vivek, over to you.
Yeah. So this is a 4-year-old child who for the first time actually became symptomatic at 2 years age when she had a febrile illness with the exanthematous rash, and the rash disappeared and left post-inflammatory hyperpigmentation. So that was at 2-year age, and she recovered at that time. And then this time, 4 months prior to this presentation, she again had a fever for a month and recurrent vomiting, recovered, but was left with residual balance issues with daily early morning vomitings and headaches, but with normal sensorium. On examination, she has a cerebellar syndrome, broad-based gait, truncal ataxia, but no nystagmus, slight torticollis to the right side. So very cerebellar child. Unfortunately, I don't have a video now. So, but she was fully conscious and normal speech. On examination, she didn't have any meningismus. She actually, on eye examination, had a posterior uveitis. Interestingly, a sibling had died with recurrent fever at 2 to 3 months age, which was treated as pneumonia. And 2.5 year age, he died, but from 2 month age, he was having recurrent fevers. But that child also had unsteadiness, loss of balance. MRI was not available, and parents told it was normal, but cannot be sure. And that child did have pancytopenia and died at 2.5 years age. So fever followed by cerebellar syndrome. So this was a presentation. So you want to show the MRI, Nihaal?
Yeah. So MRI on top is the diffusion sequences. I hope you can appreciate the focal abnormalities, the posterior periventricular white matter. I think along the bilateral posterior putamen out there, the perisylvian region on the left side.
Not
maybe the
yeah.
So on the cerebellum also had these mixed edematous changes. I think better appreciate on the T2s. Yeah. So on the T2s you can appreciate this mixed edematous pattern on the cerebellum, also involving the brainstem. Hope we have a T2. Yeah. So T2s again, you can appreciate the focal lesion, the supratentorial white matter, the supratentorial brain. more confluent abnormalities or patchy abnormalities involving the cerebellum, also involving the brainstem structures. Post contrast, you can appreciate that there is some degree of fluffy enhancement in the bilateral cerebellum, some nodular foci, some linear foci of enhancement demonstrated in the bilateral cerebral hemispheres. The supratentorial lesions also demonstrate nodular enhancement. Could not appreciate the meningeal enhancement per se, maybe some degree of left meningeal enhancement on the left side. But yeah, the main findings are in the posterior fossa. So based on the imaging findings, at least thinking of possibility of HLH, genetic possibility, given that the sibling also had some degree of recurrent infections and pancytopenia. The imaging findings are almost typical of HLH. I mean, what we see in HLH, these punctate, nodular, and partially confluent abnormalities in the cerebellum and the brainstem structures. Also, there are supratentorial lesions which can be often focal or confluent, and over a period of time have some degree of volume loss. The other different imaging differentials, at least we consider, was the lymphoma, sarcoidosis, though this case did not have the typical meningeal enhancement. The pituitary and the stalk also was normal, which can also be seen in the infiltrative disorders, typically seen in sarcoids. Other remotely possible finding was the demyelination, but I think these the first two are the most likely diagnosis. Another possibility was the histiocytosis, which can also have this predominant cerebellar involvement. Yeah, so these were the imaging differentials, and yeah, Dr. Vivek,
So initial differential was HLH, primary CNS HLH, though, you know, Rossi Dorfman, that was also considered as a possibility, the LCH variant. The child had a normal bone marrow. There was normal ferritin. Because of the uveitis, ACE was done, which was high. CSF showed high protein, some cells, and FDG PET revealed very active, multiple lymph nodes. There were clinical lymph nodes, but quite active on FDG PET. Our MOG, NMO, GFAP were negative. So clinically, we considered neurosarcoidosis. Still, we cannot explain the sibling's death, so whole exome is awaited. Might turn out to be primary HLH, but treating like neurosarcoid. So we was given methylpred. She had shown improvement, gone home on oral steroid. CT chest didn't show significant, mediastinal lymph nodes.
yeah, then we looked at some the non-cacheating granulomatous lesions. I think there are a list of lesions out there.
They were non-cacheating granulomatous lesion also on the FNAC and the lymph.
Okay. And then we think of the most common abnormality with non-cacheating granulomas are the neurosarcoidosis. And if you see the examples, at least over here in the cerebellum, has these fluffy and nodular enhancement, which are seen in our case too. So sarcoidosis is a possibility now. So I think we're between neurosarcoidosis and HLH. Is that right, Dr. Vivek, or we're moving more towards sarcoidosis?
No, still sarcoid and HLH is a possibility. So whole exome I will update.
All right. Okay, Sridhar has mentioned Blau syndrome as a possibility. With the triad of uveitis, dermatitis, and arthritis. So I think we should get that on the whole exome. All right. Yeah, we'll update you with the genetic result on the possibly in the next session, or the to our last case, Dr. Vivek.
So it's a 13-month-old female child. The sibling is normal, male child. The child till 6-month age was having significant motor delays, so was not able to hold neck properly, but cognitively was quite interactive. But after 6 months, she didn't have much motor or cognitive progression, though she didn't regress. I might have the video that shows that her facial expression is much better, even though she's now dystonic in arms and legs, so generalized dystonia. Reflexes, though, were difficult to elicit. There was striatal toe. but her interaction is much better than her motor abilities. So you want to show the MRI?
Yeah. So I have two sets of MRI. This is the first MRI, I think at six months, if I'm not mistaken. Dr. Vivek?
Yeah.
Yeah, so 6 months, you can appreciate again striking abnormalities in the bilateral thalami, the median thalami and the ventrolateral thalami, some degree of abnormality along the posterior lymphomedullary capsule. There. Yeah, and then you have some degree of widened subarachnoid spaces, but for a 6-month-old can be normal. Again, the symmetrical abnormalities in the ventral medulla, the inferior alveolar nuclei are there. On the diffusion, there were no corresponding changes of diffusion or restricted diffusion, at least in the thalamic and the brainstem abnormalities. So on the FLIR sequences, there is some degree of subdural collection out there, chronic subdural collections on both sides, along with the enlarged the widened subarachnoid space along the frontal convexity. On the side sequences, you can appreciate some degree of mild volume loss of the corpus callosum or mild hyperplasia of the corpus callosum. Other than that, I cannot appreciate any other findings, significant findings on the T1 FLIR sequences. Then there was a I think it's the follow-up after 6 months. Is it right, Dr. Vivek?
Yeah, after 6 months. Yeah,
Okay,
1 year
yeah.
age.
1 year. At the age of 1 year, again, there is some degree of volume loss now in the frontal and temporal lobes. The changes are again centered in the thalamus, but I think posteriorly there is some progression compared to the previous study. New changes are seen in the cerebral, the substantia nigra out here, which was not seen in the previous study, though I don't have a slides of that this sequence. Again, the inferior alveolar nuclei, the ventral medulla changes are still remain. On the diffusion, though I don't have an ADC, there was some degree of bright signals on the diffusion sequences in the thalami. Spectroscopy was done. I think we have these two. Yeah, there is a mild inverted lactate peak out there. Cannot appreciate any other significant peaks. Maybe Dr. Vijay can help me out here, but yeah, other than the lactates, this mild elevation of the lactate, I cannot find anything significant. Then the workup, yeah, over to you, Dr.
So she had a normal blood gas, lactate, ammonia. TMS was normal. Urine GCMS will mildly increase lactate and alanine. And she has had she has had a whole exome, mitochondrial, whole genome, which is all normal in the blood. So my question was, it does look like a mitochondrial disorder. Is there any very, it probably is like a mitochondrial, but is there a posterior circulation vasculopathy which can cause all the, changes in the thalamus and the midbrain? Because the child has deteriorated motor-wise, cognitively she's remained intact. Probably in the blood cells, we are not picking up the mitochondrial disorders. So should we do a skin fibroblast assay for oxidative phosphorylation? Maybe that might pick it up because nothing has come in the blood.
But as you know, the diagnostic yield of genetic testing in mitochondrial disorders is 50% or even less. So this is very likely a mitochondrial disorder in view of the pattern, brainstem and progression.
Vivek?
Yes.
In Varia Hospital, they have this research setup. They have started doing these mitochondrial disorders. They're doing muscle biopsy as well as from the mucosa of the mouth.
Okay.
So if you
the family will also go there if needed. So is there somebody to contact?
Yeah, I'll send you the number.
Sure, sir. Thank you.
Yeah.
If you do a repeat MR in a few weeks and you will see further progression, this is again in favor of mitochondrial disorder until you wait for other special tests. But muscle biopsy is not that specific. You may find respiratory chain abnormalities, but not pinpointing to a specific genetic mutation.
They're also doing in the muscle biopsy, they're also doing mutations in the the mitochondrial genes locally. So there's a somatic mutation kind of thing. So I mean, I don't know whether it help or not, but it's a good idea to get it done.
Dr. Vijay mentioned
Right.
also has mitochondrial pediat, Golgi, yeah, coenzyme Q.
They're all covered in blood,
Yeah.
like in the blood mitochondrial blood
Mm.
cells with mitochondria. But obviously, the liver and the skin and the brain and the muscle, they have more mitochondria in their cells. With that concept of heteroplasmy, is that so? Because of which sometimes you don't pick it up in the cells in the blood, but you pick it up better in these places. So maybe that might help.
This
Yeah,
is
but the
correct, but when you have an onset in the first few months, it's more likely a nuclear gene.
Yes, autosomal recessive.
Yeah. And the pattern is like a nuclear gene because there was something
It's like a
it
Leigh
was
syndrome, isn't it?
Yeah,
Yeah.
but given the MT is usually involving the basal ganglia, the MT DNA genes, especially in the Leigh syndromes. I think there's a paper from
Okay.
CHOP highlighting
Yeah.
the involvement of the MT DNA and nuclear DNAs. So more involvement of the basal ganglia is the MT DNAs, and yeah, the other structures are nuclear DNA related abnormalities.
Yeah, a very nice diagram which
Yeah,
gives
yeah.
more
There's a heat map demonstrating
map.
which is
If you
more. So
if you consider the repeat MR, suggest to do also a spinal MR because in Lee you have often a involvement, and the initial description by Dennis Lee was subacute necrotizing encephalomyelopathy. So the myelin is often involved, at least histologically.
That is useful, but I would. So he had an MRI at 6, she had an MRI at 6 months, and now 12 months. So family probably there won't be much use doing repeated MRIs. You know, they want to answer. So it's most likely mitochondria we are telling them, but it's more the gene which we want to know rather than the progression.
So Dr. Vic, I showed this case to the first author of that paper, and he was not sure of a particular gene, but he said it looks mitochondrial. So Caesar, I showed it to Caesar, and yeah, he also was not sure of a thing. I mean, just pointed out a single gene.
Sure.
As in the paper on the chat. The question from Anas, if you have to counsel patients for next pregnancy, would we do a muscle biopsy or something else would help towards getting a diagnosis?
So that's the aim actually. If some tissue from somewhere could give us an answer. So sir will send me the contact. Probably I'll send them to Wadia.
I've sent it already.
Okay, sir.
Sonam is the person who started the research project. She was from Nimans and now she worked in Wadia. And Debolina is the actual person who does it. Check
Thank
it.
you, sir. I'll do.
This question from Salahatin, thiamine biotin response basal disease. Dr. Vika, if I'm not mistaken, the child was on thiamine biotin on after the first scan.
Loads of biotin and thiamine.
Yeah.
Large amount. Didn't work.
Didn't work, and usually there's some degree of involvement of the dorsal striatum and cortical subcortical regions in thiamine, which is not there in this case, at least typically seen in thiamine by basal ganglia disease. Okay, so hopefully we get a diagnosis or result based on the biopsy or the other tests at Wadia. Dr. Vivek can provide us with the feedback, and then we learn from Dr. Vivek about new techniques for diagnosing this condition.
Not from me. You heard from Dr. Udani already. He told us. Thank you.
Thank you very much. Thank you, Dr. Udani. Thank you, everyone. I think that's our last case. We'll meet you again on 17th of May. Please submit your cases by 15th of May. You can email me, you can message me on the WhatsApp group. We have a common Excel sheet where you can add the cases. So till 17th of May, see you. Have a good night.
Thank you.
Bye-bye.
Thank you very much.
Thanks again. Hope you're doing well.